Uh, Welcome everyone to join our annual meeting. And this is a dream come true. We build a bean clinic in Taipei. And the director is over here, PS Ru. This is my dream come true because I closed the procedure for maybe 1 year because I have no machine to do PAE. And I think the Xi'an angel machine is very cool because it's almost a smaller one, but functional is good. Okay. And in previous year, I do a lot of PAE, but I think the technique is not the problem. The problem is the response rate because the self-pay procedure, they come and you get a better outcome is okay, but you do with the poor outcome is not good. And I always think previous we can do the repeat PAE, but patient and the GU doctor not allow us to do this. So you can see the 10 years response rate over maybe six. So clinical failure rate is about 40%, and repeat procedure is about 60%. It's very high. And the majority of these patients will go to the OP, not the repeat PAE. So what is the solution? With the solution, I see many cases. I have few cases of repeat PAE. I can see the PA will recanalization. I think majority of the problem is the recanalization of the PA, and over the time they will grow the gland again. So we want to do, but actually the patient will not have a full confidence for this to repeat PAE. So maybe we do aggressive initial embolization is a better way. So maybe we can try the smaller particle, but many papers say the small particle will bring us maybe more adverse effect, but the same clinical outcome. So maybe we can consider to do the posterior artery occlusion. Previously, I think this is not a good solution because I think we can repeat the PAE in the higher or elderly age people. But in the clinic, we made a patient maybe 50 or 60 years old. They want to do once, not the second one. So with COE or with the glue is maybe a solution. This is the first case in the Bean Clinic. In the past year, I will set up a SOP for the PAE, so I do the CTA with the 3D image. I color the posterior artery, so I can find we can save the procedure time and radiation dose. In the anatomy, we know the posterior artery can come from anywhere from even the external iliac artery or common femoral artery, right? So if you only use the angiography, if the PA comes from very distal of the IPA of the obturator artery, you cannot see very easily. So the CTA will improve the outcome of your procedure. And sometimes I think that with the bone landmark is very important, and it can do with the raw map image. You don't need any more traditional angel. You just use the raw map. And that view is better than AP, that oblique view. This is an example. It's the same case. You can see the PA is from the superior vascular artery and go down. So later view you can get the excitedly position or opening of the PA. So it's very easy to get the right place, right? Okay, if I do this kind, I turn the machine back to the AP view and do the angiography. And I see or maybe it's the right of the pulmonary artery, and I get the patient to use the CCB or NTG before I do the combined CT, and I save the radiation dose. This you can see that left side, patient left side is a glue embolization before, but now I do this time is the glue lipido ratio is a 1:8 with the free flow injection, but I think it's still not so penetrate to deep to the grain. Maybe the flush, the D5 watt flush is maybe more. Not like the usually we do the breathing or pseudoaneurysm. We do more flush and we can go deeper of the grain. This is final angiography. The PES is a minimal, maybe minimal dysuria only 1 day. So far so good. The natriuria is decreased to once and stop the alpha blocker now. This is the ideal penetration of the glue, but I think we should try more and learn the experience. Maybe we can use occlusate, or maybe we can flush more and did not fail with the thickness of the microcatheter, right? And I think the glue and emulsion, the glue, we treat the grain and with the PA occlusion. So the initial response in paper is higher. The glue emulsion is in few seconds, maybe not over 10 seconds. But embosphere emulsion, maybe each side you need 10 minutes more. And because we know the distal anastomosis, we can open the anastomosis because of the pressure. So because the glue is opacity with the lipido, so there's less risk for non-target embolization through the distal anastomosis. And better see the treating wrong during the procedure, not using the post-procedure combing CT. But in another case, I still feel dangerous. I try to use the embosphere first and the glue later. But this is very difficult because for me, maybe the embosphere embolization is not really clear for the endpoint. So this PA is from the internal pudendal artery. So now I use a raw map and sometimes I get the applicable view to see the opening. So this is after the embosphere. This is too late for the glue embolization. So I didn't use the glue in this case. The conclusion, I think glue is a safer, effective in the short-term outcome, and it's a faster way and low radiation dose. It's a clear endpoint and better visualization, and you do the artery occlusion at the same procedure. But the drawback is the learning curve, because in my career, the glue is not familiar for me. So I will want to try and learn more. But the long-term outcome is not yet.两年 papers say, and the glue penetrated, or we should combine the embosphere with the glue is still not known. Thank you.